Hello everyone, I'm Anas Al-Ubaidi, and the topic for this session or this lecture is documentation challenges for neurological conditions and common ophthalmic disorders. It is within chapter 29 of the Review of Neurology and Ophthalmology Scribing within the Certified Medical Administrative Assistant course program by ACMSO. Introduction. Accurate and comprehensive documentation is the backbone of effective patient care, especially in complex specialties like neurology and ophthalmology. The lecture on documentation challenges for neurological conditions and common ophthalmic disorders aims to equip medical scribes with in-depth knowledge and skills to tackle the intricacies associated with these fields. Neurological conditions such as strokes, epilepsy, multiple sclerosis, and Parkinson's disease are characterized by their diverse presentation and often overlapping symptoms. Similarly, ophthalmic disorders, including glaucoma, cataracts, and diabetic retinopathy, require precise and detailed records to assist in accurate diagnoses and to track disease progression. Neurological documentation presents unique challenges given the complexity of symptoms such as headaches, dizziness, paresthesia, or seizures, where even subtle details can dictate different diagnoses. For instance, documenting the timing, frequency, triggers, and associated aura in a migraine is critical for distinguishing it from a more serious condition like a subarachnoid hemorrhage or SAH for short. Likewise, neurologists rely heavily on a medical scribe's ability to note down a neurological examination outcomes, a diagnostic imaging reports, as for instance, for example, MRI or CT scans, and therapeutic interventions such as anticoagulation for stroke management or the use of anti-epileptic drugs. Missed details in these areas could lead to critical delays in patient care and treatment efficacy. Meanwhile, ophthalmology requires a high degree of precision due to the technical nature of its diagnostic measures and the immediate implications for vision preservation. The field often involves advanced imaging technologies like optical coherence, like optical coherence OCT, which is optical coherence tomography, or fluorescein angiography, which must be recorded with utmost accuracy. For example, consistent tracking of intraocular pressure (IOP) in glaucoma patients can be the difference in preventing irreversible vision loss. Similarly, in cases like diabetic retinopathy, proper documentation of injection dates of anti-VEGF or VEGF therapy helps control disease progression. Ensuring completeness and clarity in ophthalmic records not only assists ophthalmologists during patient care but also facilitates continuity of care among multidisciplinary teams. Medical scribes in these specialties face overlapping challenges, from capturing complex examination findings to adhering to strict compliance and coding regulations. Neurology and ophthalmology often share a need for detailed procedural documentation, such as post-thrombolytic monitoring for a stroke patient or preoperative evaluation for cataract surgery. Furthermore, these disciplines often involve emergencies that demand time-critical action, making it essential for scribes to record information in real time without disrupting the clinical workflow. Further complicating these demands are conditions that cross over between the specialties, such as optic neuritis. This condition can signify an underlying neurological disease, like multiple sclerosis, and requires simultaneous neurological and ophthalmological considerations, a scenario where precise, well structured documentation becomes indispensable. Key points: symptom documentation for neurological conditions, headaches and migraines, overview. Neurological conditions often manifest with headaches, including migraines, cluster headaches, and tension headaches. Documenting these requires a focus on timing, triggers, intensity, and associated symptoms, like nausea, visual disturbances, or photophobia. Example: patient reports throbbing headache, right sided, onset 4 hours ago, associated with nausea and visual aura that appeared 30 minutes prior to the headache. The importance here differentiates primary headaches, for example, migraines, from secondary causes such as subarachnoid hemorrhage or meningitis. Seizures and epilepsy. Documentation focus here detailed descriptions of aura, duration, type of movements, post-ictal state, and frequency are essential. Example: generalized tonic-clonic seizure lasting 3 minutes, patient confused and drowsy for 20 minutes post-seizure. Importance here enables neurologists to determine seizure triggers, track medication effectiveness, and assist treatment adjustments. And here is a diagram summarizing the types of headache or types of headaches. Paresthesia and weakness. Documentation requirements here includes duration, progression, location, and associated factors such as neck/back pain or trauma history. Example: numbness and tingling in the right hand, onset 5 days ago, no associated neck stiffness or trauma. Importance here helps identify neurological deficits related to conditions such as multiple sclerosis, neuropathy, or stroke. Movement disorders. Focus areas here: frequency, characteristics, and patterns of tremors, rigidity, or other abnormal movements, along with functional limitations. Example: resting tremor observed in left hand worsens with stress, non-tension tremor noted. Importance here assists in distinguishing between Parkinson's disease, Huntington's disease, or essential tremor. Cognitive and memory issues. Documentation focus timing of onset, associated symptoms, for example, disorientation, behavioral changes, and any triggering events. Example here: short-term memory loss noted over past 3 months, forgets recent conversations, no agitation or hallucinations reported. The importance here helps assess conditions such as dementia, delirium, or brain injuries. And here is a diagram summarizing the documentation requirements. Symptom documentation for ophthalmic disorders, vision changes. Examples of required details: onset patterns, sudden versus gradual, associated pain and visual acuity changes. Example: blurred vision OD started abruptly after bending down, described as curtain falling in the field of vision. Importance here helps in identifying retinal detachment, vascular occlusions, or corneal conditions. Eye pain details to capture duration, severity, and associated symptoms such as redness, discharge, or photophobia. Example: acute pain OD, 8 over 10 on severity, associated with headaches and decreased vision. Importance guides diagnosis of acute angle closure glaucoma, scleritis, or other serious conditions. Floaters and flashes. Documentation necessity here: note number, frequency, and any association with vision changes. Example: patient sees sudden increase in floaters described as black dots accompanied by flashes of light OS. Importance here indicates conditions like posterior vitreous detachment or retinal tears requiring immediate intervention. Redness and discharge. Required details: nature of discharge, watery purulent, redness intensity, and any systemic symptoms. Example, fever. Example, redness OS for 3 days, purulent discharge noted upon contact with eyelid. Importance assists differentiation between bacterial conjunctivitis, uveitis, or corneal infections. Progressive vision loss. Focus notes here. Document the timeline, context, example, dark to light adaptation issues, and associated conditions like diabetes. Example, gradual central vision loss, OD, over 4 months, no associated pain or a photophobia noted. Importance here critical in diagnosing conditions like cataracts, macular degeneration, or glaucoma. Diagnostic standards for neurology, neuroimaging, CT, MRI. Essential notes include findings, clinical significance, and follow-up recommendations. Example, MRI reveals hyperintense lesion in the left parietal lobe consistent with ischemic stroke. Purpose here confirms neurological findings and guides treatments. Electrodiagnostic studies, EEG, EMG, required notes indicate patterns, suspected conditions, and comparative changes over sessions. Example, EEG shows generalized spike and wave discharges, confirming diagnosis of epilepsy. Importance here tracks electrical abnormalities correlating to epilepsy or neuropathies. Diagnostic standards for ophthalmology, slit lamp examination details to capture abnormalities in corneal lens or anterior chamber structures. Example, slit lamp shows significant corneal ulcer OS with hypopyon formation. Importance provides critical visuals for conditions like corneal ulcers or keratitis. Fundoscopy, focus and formation, visualized retina-optic disc changes in any hemorrhages or vascular anomalies. Example, disc swelling, observed OS. Flame-shaped hemorrhages present at 9 o'clock position. Purpose, helps diagnose hypertensive retinopathy or optic neuropathies. Handling complex cases, neurology/ophthalmology crossover conditions, documenting optic neuritis include onset of vision changes, pain upon eye movement, and MRI findings. Example, MRI shows enhancing lesion at optic nerve head OS, correlating with pain and vision loss diagnosis. Importance, optic neuritis may be an early sign of multiple sclerosis. Multidisciplinary care role documentation. Example, in neurology collaborated with cardiology to initiate anticoagulation and atrial fibrillation-induced stroke. Example, in ophthalmology, referral to endocrinologist for an uncontrolled HbA1c, contributing to proliferative diabetic retinopathy. Summary tables. Here we have table on neurological symptoms and documentation requirements. Symptom, key documentation elements, example, diagnostic importance, risks of poor documentation. Symptoms, we have headaches, motor weakness, paresthesia. We have cognitive issues and seizures. Here we have table on ophthalmic symptoms and documentation requirements. Symptom, key documentation elements, example, diagnostic importance, risks of poor documentation. Symptoms, blurry vision, eye pain, floaters and flashes, loss of vision, redness, and discharge. Here we have table on neurological diagnostic procedures, diagnostic test, key documentation components, example, diagnostic importance, risks of poor documentation. Diagnostic tests, we have CT scan, MRI, EEG, EMG, lumbar puncture. Here we have table on ophthalmic diagnostic procedures, diagnostic test, key documentation components, example, diagnostic importance, risks of poor documentation. And diagnostic tests, we have OCT imaging, fundoscopy, visual acuity, VA, slit lamp exam, fluorescence angiography. Table on multidisciplinary documentation in neurology and ophthalmology, scenario, specialists involved, key documentation points, benefits of collaboration, risks of poor coordination. Scenarios, we have stroke with visual changes, diabetic retinopathy, optic neuritis, cognitive decline, and then uveitis and systemic disease. Next, we will revise what we have covered through this lecture via some MCQs or multiple choice questions. Question 1. Which symptom detail is most critical to document when evaluating a patient for a potential stroke? A. Whether the patient has any known vision changes. B. Timing of symptom onset with associated neurological deficits. C. Pre-existing medical history such as hypertension or diabetes. Or D. Results of previous ECGs or echocardiograms. The answer would be B. Timing of symptom onset with associated neurological deficits, as stroke management is time sensitive due to treatment options like thrombolysis, which depend on identifying the time of first symptoms. Accurate documentation ensures rapid decision making and appropriate intervention or interventions. Question 2. When documenting a case of primary open angle glaucoma, which of the following is the most important to include? A. Presence of redness and discharge in the affected eye. B. IOP measurements, optic nerve assessment, and visual field testing results. C. Resulting from the patient's most recent OCT imaging. Or D. Patient complaints of photophobia or eye pain. The answer here would be B. IOP measurements, optic nerve assessment, and visual field testing results. As a primary open angle glaucoma often progresses without symptoms like pain or redness. Documentation of IOP, optic nerve cupping, for example, cup to disc ratio, and visual field damage, is essential for diagnosis and monitoring disease progression or treatment effectiveness. Question 3. A patient presents with episodes of flashing lights and a visual field defect resembling a curtain falling over their eye. What documentation priority should the scribe focus on? A. The patient's corrected visual acuity before the episode started. B. Retinal imaging results and noted areas of detachment. C. Details of systemic conditions like hypertension or diabetes. Or D. A family history of similar visual symptoms or ophthalmic conditions. Answer would be B. Retinal imaging results and noted areas of detachment, as flashes of light and visual field defects suggest retinal detachment, which requires urgent intervention. Proper documentation of retinal imaging findings supports timely surgical planning to prevent complete vision loss. Question 4. Which is a key phrase to document for a scribe assisting the diagnosis of optic neuritis? A. Painless progressive loss of central vision. Optic nerve shows no abnormality findings on MRI. Retrobulbar pain worsened with eye movement. Central vision loss noted OS. Or C. Severe generalized headache with nausea but no visual eye changes. Or D. Peripheral vision field loss stable over 2 months. So answer is B. Retrobulbar pain worsened with eye movement, central vision loss noted OC. Optic neuritis commonly presents with painful eye movement and central vision loss. Accurate details regarding these findings as well as correlating MRI results are vital for assessing conditions like multiple sclerosis. Question 5. How should the scribe document findings during fluorescein angiography for a patient with suspected diabetic retinopathy? A. Description of cup to disc ratio findings during fundoscopic exam. B. Presence of microaneurysms, neovascularization, and macular edema. C. The patient's blood glucose levels and HbA1c values. Or D. Results of the patient's most recent optical coherence tomography, OCT. So the answer here would be B. Fluorescence of microaneurysms, neovascularizations, and macular edema. As fluorescein angiography focuses on detecting retinal vascular abnormalities like microaneurysms and neovascularization, which are hallmark findings in diabetic retinopathy. Clear documentation of these findings is crucial for guiding laser or anti-VEGF therapy. And here we come to the end of this lecture. Thank you very much and goodbye.